Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia. Today we hear from Associate Professor Kirsten Auret, the Clinical Director of Palliative Care at the WA Country Health Service, about voluntary assisted dying. Professor Auret is joined on the phone by Dr Olga Ward.
Well, Kirsten, welcome to the podcast.
Thanks, Olga. It's been a long time.
It has indeed, and a considerable amount has happened in Western Australia with regards to voluntary assisted dying. And despite the long lead time, I think it kind of all hit us with a bit of a rush.
It did seem to, didn't it? So full enactment happened on the 1st of July of this year.
So how does the whole process work?
Well, I'll start by saying I guess none of us are voluntary assisted dying experts, and I come to this conversation very much as a rural palliative care specialist. But because I was a member on the expert panel that advised the government about the legislation, I've kept very close to the details of the legislation and the implementation process since then. So how does the process work? Well, I think during the 18-month implementation phase, we were very much taking the legislation and then trying to figure out how would it work on the ground, what processes and systems would we need in place. So if you like, I could talk a little bit about the framework of the legislation, and then we could talk a little bit about the systems that are on the ground to kind of make it work. How does that sound?
Yep, that sounds good. Practical tips on how the legislation applies to the doctor on the ground would be much appreciated.
Okay. So I guess the first really major thing is that the legislation means that voluntary assisted dying is now legal in our state. So during the implementation period of time it wasn't, but from the 1st of July it is. And there have been a number of patients in our communities that have decided to die by voluntary assisted dying since that time. And they've had doctors who are appropriately trained and credentialed assisting them in that role. So I guess the first take-home message is that there are now universal responsibilities that doctors have to understand under the Act, which requires them to know how to respond if a patient says, I want to request voluntary assisted dying. We can talk a little bit more about what those are. But then they need to understand that their patients that are terminally ill do now have a process that they can undergo to see whether they would meet the requirements for voluntary assisted dying prescription and administration. So essentially their patients need to be terminally ill, and they need to have a expected prognosis of 12 months or less, or to have a prognosis of, so she said 12 months or less is really for patients with neurological or neurodegenerative conditions, and otherwise it's 6 months or less for all other diagnoses. And that patient needs to be suffering in a way that they feel intolerable. They need to be of sound mind and have full legal capacity. And they need to be a resident of Western Australia. And obviously they need to be an adult. So it really is focusing on people who are at the end of their life from an illness that is progressive, that is going to take their life in the foreseeable future, and it allows them a route of exploring whether voluntary assisted dying will be how they die at the end of their life.
So how does that whole thing integrate with palliative care for you?
Well, I think what's sort of happened on the ground already for me and many of my colleagues working in palliative care is that patients want to talk to us about voluntary assisted dying. They want to find out more about it, and sometimes they want to progress to making a formal first request and going on through the process of assessment and perhaps dying by voluntary assisted dying. So I think the first thing is that we know from both the Victorian and international experience that the majority of patients who die by voluntary assisted dying are known to palliative care services. In fact, in Canada, something like 97% of patients who died by voluntary assisted dying are in the palliative care service at the time. So clearly from the patient's perspective, there will be a real interplay between palliative care services and voluntary assisted dying models of care. However, really, for many palliative care providers, they would feel that voluntary assisted dying is not palliative care, and that they would continue to provide what is seen as traditional palliative care symptom controls, like a social, emotional and spiritual support to the person and their family right until the time of death. And for some, they will also engage with the voluntary assisted dying process. Perhaps they will be a coordinating or consulting practitioner. Perhaps they would be an administrating practitioner. Perhaps they would be a nurse or doctor at the bedside when the patient died by voluntary assisted dying. That is obviously an individual choice that each healthcare professional has the complete legal right to decide where they want to be involved. However, there is an expectation that healthcare providers would not abandon a patient who wants to talk or progress through voluntary assisted dying. So the expectation is all normal palliative care would continue for that person, even if the healthcare providers in a palliative care team perhaps felt uncomfortable about voluntary assisted dying themselves.
That's great to hear. I think when this was being debated, it almost, I almost got the sense that palliative care and VAD were kind of being set up as opposite each other. And to me, this just sort of seemed like one more option that the patients can request within the palliation of their terminal illness.
Yes, very much so. And I think most palliative care teams have responded by continuing to be profoundly patient-centred and excellent communicators, like they always are. And then within their own practice, they've decided where is their own personal comfort point, where does their own morality stand in this regard, and then they've needed to make active decisions about what part of this process will I be engaged with and which parts won't I be. So, for example, a nurse or a doctor may elect that they would not want to be at the bedside of a patient who was taking a voluntary assisted dying medication despite being their palliative care provider. But others would say, you know what, I will be at the bedside. I feel comfortable with that and I would see that as part of my role. And I think we're still on that journey of palliative care teams of learning for ourselves and within our teams, where does everyone sit in this space? It clearly on the 1st of July became a very now problem, where I think, as you said in your intro, perhaps because of COVID, we perhaps hadn't spent enough time thinking about what this would mean for our own practice or what it would look like in our teams, and how would we respond the first time a patient brought it up with us, and what would our legal responsibilities be? It all seemed to come as a sudden rush, and many of us in palliative care have now had that first and second and third conversation.
If a patient does have a terminal diagnosis, what are the legalities around VAD being mentioned?
So I think one thing that's important to note, particularly if doctors are looking at the Victorian legislation, is what can be mentioned in Victoria and what can be mentioned here is different. So essentially here, a registered healthcare worker may not bring up voluntary assisted dying. However, a doctor may. So a doctor can bring up voluntary assisted dying as long as that's occurring in the context of a consultation and as long as it's occurring in the setting where they really are doing what you've suggested, Olga. They're talking about the options for care at end of life. So they're talking about active treatment options, they may be talking about palliative care, they're talking about voluntary assisted dying, all as part of a suite of choices to help inform that patient. And that's the difference between ours and the Victorian legislation, because doctors may not do that in Victoria. Once a patient has brought it up, a healthcare provider, be that a nurse or a social worker or a physio, can then take up that conversation and talk to them more about it. But the requirement under law is once that conversation has been opened up, we must provide the patient with the required information that comes from the health department's website, which essentially is, if you just Google Health Department WA, voluntary assisted dying, you'll see on their webpage that they have the mandated information you have to give. It's simple language information, and there has been some limited so far, but increasing attempts to provide publications in very simple language for people of low literacy, to get it translated into different languages, and to look at what that needs to be presented as for our Aboriginal patients. So really, if you're bringing it up, or if a patient brings it up with you, the first thing to know is you need to provide them this particular written information. You can't just find anything. You must give them this information. And the second thing is, if during that conversation, either brought up by the patient or progressing out of what you've been talking about with them, they say, you know what, I do want to request access to the voluntary assisted dying assessment process, or I do want you to help me get that pill. Or if they even use these words, this is my formal first request. It is a first request. And whether or not as a doctor you plan to continue to support that patient, you are legally required. You must log that first request with the Voluntary Assisted Dying Board. And again, to log that first request is a matter of just Google logging first request, Health Department WA. You'll kind of be linked through to the right page, and that goes up to the Voluntary Assisted Dying Board. And that is a requirement whether or not you intend to support that patient any further. And it is a requirement whether you were an intern receiving that formal first request, or the registrar, or in general practice, or in a remote area clinic. Wherever you are, if you're the doctor that's received that first request, you have a legal obligation to provide them the paperwork and log that first request online.
Okay, so with logging something like that, I'm thinking about numbers of my patients who've been nervous about two things. One is my patients are often quite frightened of going online, so the doctor actually logs that for them.
Yes, so the doctor has to do the first request. Yeah. The patient doesn't, the doctor does.
The doctor will log that. And the other thing is, what happens if the patients often feel quite uncomfortable about even wanting to talk about this, if they're in a Catholic facility or another religious-based facility where the official line is this is not happening. What happens for those patients?
So all those facilities, so our hospitals that are run by faith-based organisations and our residential aged care facilities, will have policies that were required to be developed that will talk about how the patients in their services will be supported. So I think the first thing to do is, if you work in a faith-based institution, I would reach out and say, how do we support a patient that might be interested in finding out more about voluntary assisted dying? What am I allowed to do under policy in this organisation? But many of them will have a way of providing patients with the information that they'll need to progress things themselves, which essentially is giving them access to the statewide Care Navigator service. And as a doctor, that's probably one of the most useful things for you to know as well, is that there is a office hours statewide Care Navigator service for voluntary assisted dying, and they're open from 8:30 to 5 on normal working days. Their phone number and their email will be up on your website, I understand, associated with the podcast. But if you're not sure what to do as a doctor, you can call them and they'll talk you through what your role is and how they might support the patient. And equally, the patient or family member can reach out directly and say, look, we're interested in finding out more, and they'll be supported through that information process. The Statewide Navigator service equally might reach out to you as a doctor and say, you know what, one of your patients didn't really feel comfortable telling you themselves, but they've now given us consent to let you know that they are accessing this process, and then they'll talk with you about what you want to do in terms of walking beside that patient during the assessment and prescription process.
Now, what would happen for my medical colleagues who are really uncomfortable with or absolutely diametrically opposed to the process? How do they kind of handle this? They're still legally required to put in the first request?
They are, yes.
Is there something in the first request that can say, I don't want to be involved?
Yes. So after, you can really just say, I am just logging the first request as I need to, and that's all you do. Yep.
Fantastic. Okay. And then who does the assessments? And given that some of us work in pretty remote places, how?
How? Okay, so there is a very formalised assessment process. So step one is this first request. And then practically what's happening at the moment is nearly all of us are phoning the Statewide Navigator service and saying, what do I do now? So they have a sense of who's a contact in a region. They might know of a couple of doctors that have done the appropriate training. They may have contacts in WA Country Health or Rural Health West, or just through their own networks that they can start reaching out to find out who might we be able to get to help this person wherever they might live. But they also have contacts in the city. So what they are needing to find for that patient is 2 doctors who are willing to be involved. The first doctor is called the coordinating practitioner, and they really have that primary role of coordinating the first assessment, making sure the patient meets all the assessment criteria and that they have full capacity and that they do understand what this process is about. They then have the responsibility of referring on to a second person that's called a consulting practitioner, who is also another doctor. That second person is really giving that second opinion. Yes, this person has capacity. Yes, this person would meet the criteria. They are voluntarily and in a non-coerced manner progressing through this process, and that information is given back to the coordinating practitioner. The coordinating practitioner is responsible for uploading a lot of that information onto the Voluntary Assisted Dying Board website. And then they are the ones who apply for authorisation to either write a script for an oral medication or for an intravenous medication. And if it's an intravenous medication, they will usually be the person that will administer the medication to the patient. So practically what's happened at the moment with more remote patients is that there was a conversation in Parliament about 4 weeks ago, which then came out through Hansard, so now is in the public domain, suggesting that there are 8 doctors who have done the appropriate training in the regions to be able to assist the patient in this regard. And there are about 30 in the city. So you can see that actually getting a patient close to a doctor close to the patient is probably quite unlikely. So there are funds, central funds, a bit like a PATS fund, to allow that doctor to travel to the patient, or if the patient's well enough for them to travel to the doctors. Telehealth can be utilised for many aspects of the assessment, but not all, and you would need to work with the Statewide Navigator service around that, because there are legalities at the Commonwealth level about discussing voluntary assisted dying over a communication carrier.
Yeah, I remember that when they were drafting the legislation. We were asked to input, and that was something I was particularly concerned about. If somebody's on a really remote station, that's going to be, they want to go home to die.
Yeah.
That actually produces a large number of difficulties.
Well, practically what's happened is that a number of the consultations have occurred by telehealth, particularly the consulting practitioner or getting a third opinion about prognosis, etc., have occurred by telehealth. What seems to be quite clear at the moment is the actual instructions about taking the medication needs to occur face-to-face. And so practically what that's meant is that the statewide pharmacy service have been travelling to patients directly. So the statewide Navigator service is based at Fiona Townley Hospital. The statewide pharmacy service is based at Sir Charles Gairdner Hospital, and they will be flying out to the patient in the region or to the administering practitioner, providing them the education required about how to take the medication, and they will all do that face-to-face.
What happens next? And what happens if the patient's kind of getting frailer and frailer, or, has requested the oral medication and can't swallow?
So in theory, for most patients, there is a minimum time that needs to be taken for the process, which is 9 days. That's a safeguard around the thought that a patient needs to have an enduring desire to die by voluntary assisted dying. However, if the coordinating and consulting practitioner feel that the patient's deteriorating really quickly and is likely to die within that period, they can apply for that to be that time to be minimised as much as possible to even within 24 hours. Practically for our patients that live further away, getting them the medication may well be the rate-limiting step. But there is the capacity for a conversation about this needs to be hurried up. The patient's going to lose capacity, the patient's going to die.
Yeah, yes, and the losing capacity is quite frightening, really, isn't it? Because they can get quite confused if they're needing large doses of opiates.
That is a concern, and if the patient loses capacity for whatever reason, at any point in the process, it must stop. So it cannot continue if the patient is unable to give that last, yes, I want to go ahead with this, at the point of administration. So if they lose capacity at any point, the process must stop. So just going on to what happens next. So the coordinating doctor, if all the assessment requirements have been met, will apply for a permit to prescribe. I guess the kind of overarching idea was that the majority of patients would want to take the medication orally in their own home at the time of their choosing. However, some patients are unable to swallow or would prefer practitioner administration, and the doctor and the patient will negotiate this between them, but the coordinating doctor must apply for the right permit. You can't just tear up one script and write another one if a patient's been unable to swallow later in the process. You'll have to reapply. Mm-hmm. So the patient will either be provided with a script for a mixture of oral medications, which they'll take at the time and place of their choosing. And with that, they will nominate a responsible person that will be legally responsible for making sure that any unused medication is appropriately disposed of. And again, there are formal disposing facilities throughout the state, which again, the pharmacy service helps give you information about. If you're the doctor who's going to administer it, or you have asked a nurse practitioner to administer it for you, you will receive that medication directly into your care. You will receive the education about how to use it, and you will be responsible for disposing any unused stock. And then that is given as an intravenous injection.
What if they need IV access and we can't actually get a vein?
Yeah, absolutely. That is something that the coordinating practitioner and the patient will need to talk about. How will we get venous access if this is what we're going to do? So for a person who can swallow, they should swallow it. That would be the solution for that patient. And if they felt, I'm happy to do that, but the thought about an intravenous administration is that you would be there with me and you would make me feel safer, that can be discussed. Who would you need to be with you to feel safe? And for some people, it's not the intravenous nature of the injection, it's the fact that the practitioner is there beside them at the time that makes them feel comfortable, and so that can be unpacked, and the choices that are most appropriate for that person's physiology can be made.
The patient can then die wherever they want, yeah? So some of them might choose to die in a hospital or a hospice or at home, yeah?
Yes. So I guess in terms of a facility, the first thing to say would be, as you've mentioned before, that some facilities, particularly faith-based, will not allow voluntary assisted dying to occur in their facility. All the public-run hospitals will allow that. But for many hospitals, they would feel that this, to a certain extent, is an elective medical procedure, and they would want to work with the person and their family about when could we support you the most appropriately. What day during the week could we have the right staff for you? Is there a time where your privacy would be easier for us to manage or harder? Is there a location in our facility that would be more comfortable for you than somewhere else, and when would that space be available? So like everything, there'd be some negotiation around that. In your own home is in your own home. And about, again, talking about experience elsewhere, perhaps even a third of patients who have the oral medication in their own home will elect not to take it and will die by natural means at some time. And the medication has provided them perhaps a sense of control and safety, but equally they've decided that taking the voluntary assisted dying substance is not how they want to die. And then that medication must be disposed of as under the law by their responsible person.
Yep, so does that kind of come as a little written contract or something?
The person is formally appointed and they are educated in their responsibilities by the pharmacy service. Mm-hmm. They have about 2 weeks to dispose of the medication after the person's death, understanding that often the responsible person may be a family member, and asking them to fulfil this legal requirement immediately after the death might be a time of quite complex grief for them. Or they may, as you say, if the person died at home, be physically a long way away. So they are given time to get to a disposing facility to get the medication removed from the community.
Yeah. And then once the patient has died, what's on their death certificate?
So again, under the details of the Act, you may not write that the patient died by voluntary assisted dying on the death certificate. during community consultations prior to the legislation being discussed in Parliament, there was a very strong feeling from many community groups that the death certificate being a public document and a document that your family and community may have access to, that this is a private matter, and that it would limit patients' freedom of choice if they felt there would be consequences for the family that they left behind, or whether their mode of death might cause distress in their family after they've gone. So you may not write voluntary death, you write the disease that made them eligible for voluntary assisted dying, be that cancer, end-stage heart failure, whatever it may be. However, at the same time, you do need to again log on to the Voluntary Assisted Dying website and log the details of that death for the Voluntary Assisted Dying Board to then review. So each voluntary assisted dying death is reviewed by a board, and intermittently they provide a public report and feedback to government about who, in a de-identified manner, how many patients have accessed voluntary assisted dying and when there were any particular concerns. So at a system level, the system knows who dies by voluntary assisted dying, but the individual person's family will receive a death certificate that does not mention voluntary assisted dying.
And say if they took an oral substance at home, who logs it?
So the coordinating practitioner will need to be the one that logs it. So they need to be part of the loop with that patient and family that the voluntary assisted dying medication has now been taken. For some people, the coordinating practitioner will be their GP or a doctor that's involved long-term in their care. And for others, it will be a new practitioner. So how that communication is going to happen needs to be discussed. And I'd just like to reinforce that in my experience, most of the people that I've been involved with who have elected to die by voluntary assisted dying in the region, for the majority of them, the doctors that did the assessment or prescribing or administrating were not their usual doctors. However, the role of the usual doctor was still so critical in providing that extra support, just the usual care, the usual general practice, the usual palliative care, the usual medical management of their conditions right to that last minute, and the support that the patient, family and the other doctors that are involved in the VAD process have got from the usual doctors has been almost a deal breaker, I feel, in terms of the quality of the experience from the patient's perspective.
That sounds like a really great way of building a kind of a temporary team around the patient.
Absolutely. That is such a great way of looking at it. There does need to be a temporary team. I think one of our learnings has been that because there is a lot of newness about the process and people trying to feel their way both, I guess, morally, practically and legally through a process that they've perhaps never done before, is that the normal team communication has, in some of our early attempts to care for people, fallen down a bit. So, for example, the GP may have put their hand up and said, I didn't know what was going on. I felt very left out. So really working with the person to say, look, you have a care team around you. Can we have your consent to talk about your care like we normally would, to inform the relevant people of key points in time or changes or decisions that are being made? And nearly ubiquitously, patients have said, of course, I'd much rather my care team were around me and coherent and open than a whole lot of secret squirrels happening and leaving people out.
Given that there are so few rural practitioners, Kirsten, and that many of us are very keen to support our patients in whatever way we can at whatever stage of their illness they happen to be, how do doctors get involved with this process?
So I'd say there's three ways. The first one is to be willing to have these sorts of end-of-life conversations with our patients. We know they're hard. Some of us feel more comfortable than others. So just practicing talking about end-of-life choices across the range with our patients as part of our normal practice. I think that's the first way of getting involved, letting your patients know, you know what, I'm okay talking about this sort of stuff. And they'll pick that up and they'll be the ones coming to you and saying, actually, I want to talk about this a bit more. The second way is making sure that perhaps on your practice software or whatever, you've got the links to the first request logging and that you have the links to the information you must provide the patient. Then if you want to be a coordinating or consulting practitioner to look after either your own patients, which is how many of us first step to that point, or just look around in your community and talk with your colleagues and go, you know what, a couple of us have to do it. I'm willing to, and I'll carry that role for our community. you then need to follow a formal process. So again, it's a matter of just Google, again, Health Department WA, Voluntary Assisted Dying. There's a health professional section, and there's a link which will take you to how you apply to the health department for the first step, which is for them to consider you a fit and proper person. You do have to be a qualified fellow or a person with general medical registration for 10 years or more. You need to have nothing concerning on APRA. You need to have a couple of peers that will say, yep, you're a good doc, and you need to have your CV ready to go and be uploaded. Then a delegate of the Chief Medical Officer will look through all of that and phone your peer referees, and then they will say, yes, absolutely, here you go, here's access to the training modules you must do. The training modules take round about 8 hours, and I've had colleagues say, you know what, I needed to have the headspace, not just the time, because some of the concepts were quite challenging for me. I needed to stop and think. People have decided perhaps to do them together in small groups. But once you have completed the modules and the associated assessments, you will then become a certified practitioner to be able to fulfil the requirements of the Act to be a coordinating, consulting or administering practitioner. Of interest, there are no nurse practitioners at the moment in the state that have done the training, and that's something that perhaps we can work with our colleagues about. If your patient wanted to die, for example, in a regional hospital, and you didn't have credentialing for that hospital, WA Country Health's working hard on getting credentialing processes for doctors who are willing to come into the hospitals to support patients in voluntary assisted dying, even if that's the only role that they would fulfil in the local hospital. So definitely, if that situation applies to you, work with your local medical director, chat to them about the fact that you do want to be able to provide this service, or that you've got the first patient. Use the system's kind of newly developed processes to allow you to be credentialed in that facility and to discuss payment for services that you offer within the facility.
So, and would that be billed to WA Country Health or to the patient directly?
So if you are providing services within WA Country Health for an inpatient, it would be billing WA Country Health.
And otherwise, if you're just seeing a patient at home, you just sort with the patient.
Yep, so whether that's a Medicare billing as a usual consultation, obviously there are no billing mechanisms through Medicare for voluntary assisted dying, so it would be your normal consultations. I have to say that experience from elsewhere suggests that a degree of this work is definitely pro bono. And so those conversations about how many doctors in our community are willing to do the work, I think are important, because the small number of doctors who are doing it now have taken on a burden of time, financial loss, and travel often away from their families and their own workplaces to support our patients in our communities. So it is a conversation worth having, but I do think there needs to be a recognition, if you are considering doing this work, just like lots of palliative care and lots of general practice and lots of medical work, some of it's going to be pro bono, and is that something you're comfortable with?
That sounds good. I wanted to just add, Kirsten, that we're considering running through the compulsory training as a whole day workshop as part of the Rural Health West Annual Conference next April, which would give the doctors an opportunity not only to go through the training in a group, but also to discuss some of those more challenging concepts together. So that's a work in progress, and stay tuned with that one.
Oh, I think it's a brilliant idea. So well done, you guys.
Awesome. Well, thank you very much for talking to us today. Do you have any final messages for the doctors and anyone else who happens to be listening to this podcast?
Yes, my final message is get that statewide Navigator service phone number in your mobile phone. So the phone number is 9431 2755.
2755, and that's office hours, yeah?
8:30 to 5, yes. And I have to say I've had quite a few interactions with them. They are amazing. I think if you reach out to them, you'll be really supported, and you'll get the information you need, and you'll be guided through the process for your patient going forward.
Fabulous. Thank you so much for joining us today, and I hope that this has answered a lot of people's questions for us.
I hope so too, Olga. It's been lovely chatting, and all the best to your audience.
Thank you.